I'm Dr. George Moncrieff. I was a GP in Bicester in North Oxfordshire, and in the past I've been the curriculum guardian for the Royal College of GPs, and after that I became the chair of the Dermatology Council for England. So I practiced in primary care in Oxfordshire. I had an interest in dermatology as a medical student 50 years ago, but I soon discovered that I liked dermatology when I was a GP. There's a huge amount of skin disease in general practice. It constitutes a lot of our workload, and I realised that my colleagues struggled with it and their patients weren't getting particularly good care. And so in the mid-90s I went away and did a one-year diploma, following which I became one of their external examiners for 7 years. And soon after that I set up a service in the community where my fellow GPs would ask me to see a patient with a skin problem rather than sending them to hospital. And in the end, about 50 GPs, looking after a population of around 100,000, sent most of their skin problems via me. And so the nice thing was I could see them locally, usually within, sometimes the same day, often within a few days, rarely more than a fortnight. And in the end, only about 1 in 20 needed to go to the hospital. I could sort the other 19 out happily in general practice. Really rewarding. So I taught undergraduate medicine in Oxford, and I was a trainer in general practice. So in the UK, to become a GP in your own right, you have to spend 1 year attached to an experienced GP. And so for 18 years I had one doctor after another coming and spending a year with me, and I'd show them the ropes and teach them the way I like to do general practice. So very varied career. But the lovely thing about general practice is nothing isn't your responsibility. Everything is. So children, old people, cancer, pregnancy, cancer. I mentioned that. And you manage patients over a very long period of time. So a very rewarding thing to do. And you're living in the community where you work as well. I am, first and foremost, I'm a GP. But I was one of the original GPs who expressed an interest in dermatology and became a GP, formerly a GP with a special interest, which we called gypsies. And so what was it that intrigued me? Well, the fact that I could make a big difference to people's lives. Skin disease does punch much more weight than it appears. If you've got skin disease, it pervades every bit of your life, your sleep, your relationships, your ability to concentrate, your ability to get on with work. It's there with you the whole time. It really does cause enormous distress. And it's not taught. At medical school, very little dermatology is covered at all, maybe a week in the 5 or 6 years. Very few doctors who've become GPs have done any postgraduate dermatology. So as a consequence, they really struggle with managing their patients with these skin diseases, recognizing it and knowing how to manage it, and they're not getting good care. And so it wasn't difficult to correct that and deliver better care, and at the same time educate my colleagues, bring them along and say, look, this is how I do it, this is what tells me it's this, and this is how I manage that. And the outcome is the reward. It's fantastic when you see things get better. Investing a bit of time and using GP skills, which is listening and understanding and empathizing, those sort of skills, giving patients the opportunity to express their problems can make a huge difference. We talk about ICE, which is the patient's ideas and their concerns and their expectations. And it doesn't matter how good you are, if actually you're telling them what you know and not what they want to know and what they're worried about, it's a waste of effort, really. So it's establishing with the patient where they are, what they're thinking, where they're going. And because being a GP, you have that wonderful thing. You're in the community, you're living there and working there for years. You probably looked after their mother who had cancer. And so when they come with a lump, you can say, look, I'm sure what you're worrying about is this. because of your experience, but I'm confident it's not because of that. And often you can guess it, but if you can't guess it, at least consider it and then say, I wonder what you're worrying about, and then listen. Or I've had patients who come with this symptom and what they're thinking about is this. And you can say something utterly ridiculous and the patient will say, no, I'm not worried about that, but I am worried about this. And so you can use those sort of means to get the rapport going. My passion for skin disease has been kindled by the most amazing developments this century. I remember thinking in the 80s and 90s, well, medicine's done what it's going to do. We're just going to continue just to tweak the corners. But this century we have seen an absolute revolution in the way in which we understand what's going on in the skin, the importance of the skin, and we've been able to change things for the better. Because the biologicals all came in this century, but the topical treatments we've had that have come out this century are quite revolutionary, exciting. And it's continuing to evolve at the most exciting rate. It really is. And we're really beginning to understand the importance of the skin microbiome and the importance of inflammation and the different pathways that are going on and how they impact on other parts of the body. It's an incredibly intellectually exciting area to be involved in, with tremendous outcomes from that for patients. Essentially, topical steroids are very powerful anti-inflammatory drugs. They're the body's natural means of dealing with inflammation. Our body makes its own steroids. But when you put them on in a high concentration on the skin or in a localized concentrated form, they calm down inflammation quite dramatically. And many different elements of that inflammation. Inflammation is largely mediated through our immune system. And in things like eczema, the immune system's messed up and is sending out the wrong signals. And that immune system is made up of both what we call innate factors, which is the body's immediate response. Is millions of years old. Even bacteria have an innate immune system. But there are elements of our innate immune system that steroids calm down, as well as the adaptive immune system, which is how our body responds to something that's driving it, whether that's a bacteria or a virus or an allergy or whatever. And that's made up of our T cells, you've probably heard of T cells, and our B cells, which make antibodies. So these all are sending out inflammatory signals which are bad for the skin and cause the itch and cause the redness and the cracking and the skin failure. And the steroids calm that down. So they're basically acting as powerful anti-inflammatory agents. They're not usually. I think they rightly have earned a place as our standard, most effective treatment for the vast majority of patients, because they are clean, they don't smell, they don't stain, they're not unpleasant to use, and they work, and they're not expensive. So they tick all the boxes the profession could want. So when the guidelines come out, like the NICE guidelines for atopic eczema in children in 2008, they very reasonably put steroids very much as the first go-to product after emollients and detergent avoidance. I don't feel they gave emollients and detergent avoidance enough space and mention. I think that's an incredibly important part of the management of eczema. And I probably spend up to 20 minutes with a patient talking to them about how they wash and how they use their emollients. So that's the upside of steroids. And for many patients, they can use those highly effectively, calm down their flare, and taper it off, and all is okay. So I think that's a reasonable position for steroids to be. I couldn't imagine practicing dermatology without having access to topical steroids. It would be very, very difficult. There's some conditions where we really have no other alternative. So they really are, they have earned a place. And they've been around for over 70 years now. in an enormous number of ways. I want my patients not to need steroids and to come off them as soon as possible, topically. First of all, they are alkaline, and the skin normally has an acid mantle, which is actually really, really important. The acid mantle, interestingly, favors the adhesion of healthy bacteria and is antiseptic for the sort of bad bacteria that cause flares. So if you lose that acid mantle, you've lost that natural protection you have. That acid mantle also controls the activity of the enzymes, the chemicals that break down the bonds that hold the surface skin cells together. These are called proteases. And so if you lose that acid mantle and you make the skin alkaline, you can actually double the activity of those proteases. So they start busily digesting the bonds that hold the skin all together. So that's really bad news. They reduce the number of cell layers in the epidermis. That's the top layer of the skin. And so particularly in little children whose skin is very thin, that becomes a problem. And eczema tends to go for the areas where the skin barrier is most vulnerable, which are thin skin areas. Further reducing that number of cell layers makes that barrier even more vulnerable. And if you've been on a topical steroid for more than 9 months, then you've halved the number of cells in the epidermis. So the thickness is halved in a thin skin area, and so that's a concern. They reduce the amount of collagen in the dermis. Collagen is a structural protein that gives the skin tension and strength. That's in the deeper layer of the skin. And that collagen supports the blood vessels and supports the skin. Well, without that support, the skin can stretch, you get stretch marks, and blood vessels are unsupported, you can get bruising. The skin barrier is a really, really intricate and amazing and important part of what's going on in the skin. And it's right up in that top layer of the skin. The skin barrier is in the stratum corneum, the top layer of cells in that top layer of skin, the epidermis. And in some parts of the body, that's just 30 micrometers. It's a tenth as thick as a piece of paper. And yet remarkable things are going on to give the skin a barrier, preventing bacteria and viruses and other bugs getting into the skin and preventing water escaping. So if the skin barrier is breached, you've got a problem. Now that skin barrier is made predominantly by the cells just below the surface in what's called the stratum granulosa. And it's called granulosa because it's got little granules in it. And those granules are really, really amazing. They are what make the proteins that causes the skin cells to change shape. They've got the structural proteins that anchor between the bonds to hold the skin cells together. And they break down into tiny little molecules that draw moisture into their cells, so their cells are packed up tight against each other. And there are other granules that make an oily material full of ceramides, which you may have heard of. Oily material that forms, we call it a cement, but it's an oily film around the cells in the top layer of the skin to finally completely seal this barrier. It's actually massively more sophisticated than that. It's phenomenal what's going on. But those granules are depleted by steroids. If you look at skin that's been using, somebody who's been using steroids, you've depleted the granular cell layer. So you're less able to make the skin barrier in the first place. You're less able to make those natural moisturizing factors, which are called humectants, that draw the moisture into the cells. You're not making that oily material. You're not changing the shapes of the cells. You're not actually even producing the pH, the low pH, the acidic environment that the skin normally enjoys. All those little molecules that are the breakdown products of from these granules are all acids. And so that's what drops the pH and makes it slightly acidic. They often get spread onto other parts of the body where you weren't intending to get them, so they can then aggravate things like acne or rosacea or periorificial dermatitis, a spotty condition around the mouth typically, or occasionally around the eyes. So can cause problems that way. They can cause cataracts if you use them close to the eye. And the other thing about when I said they're immune suppressing, they are powerfully immune suppressing. Now when the immune system's seriously out of control, calming that down, that inflammation is doing more harm. And just calming that down is great. But there are times when you do need an active immune system, and you need your immune system doing things. And so if you've got infection in the skin, and you apply a steroid, you compromise the body's ability to fight that infection. So if you've got fungus, for example, in the skin, normally that just lives on the top layer of the skin. Give a steroid, it penetrates down into the deeper layers of the skin and becomes much more difficult both to recognize and treat. If you're very unfortunately got tuberculosis on the skin and you put a steroid on that, you can really cause things to go out of control. So a lot of problems with topical steroids. Many of them become more significant the longer you use them. It's more important talking about topical steroids in children than in adults for a number of reasons. The skin of a child is thinner, particularly in infants. They have very thin skin, which is possibly one of the reasons why we see more eczema in preschool children, because their skin barrier is weaker. Interestingly, it also gets thinner in old age. So again, they're a bigger problem in older people. But the other big problem for children is that their body weight ratio to skin surface area is different to adults. Adults have less skin for their body weight compared to a child who has relatively more skin for their weight. And that means that particularly if you're using a potent topical steroid, or even a super potent topical steroid, these are relatively small molecules. They're under 500 kilodaltons, which is the critical size. So if you've got a molecule small enough to be that sort of size, it will get through the skin. And if you use a potent topical steroid on a significant area of skin in a small child, then there's a risk that you can compromise the ability of them to make their own natural steroids. Now, those natural steroids are critical for life. And if you chronically dampen down their ability to make those natural steroids, one, their ability to produce a surge in response to an inflammatory episode, an infection or stress is compromised. Or when you stop, they can then actually take them a few weeks before they can begin to build up making their normal levels, and in the meantime, they're critically ill. So whilst that's by no means common, I think it's more common than we recognize, but it's much more likely to be an issue in little children because of their body surface area weight ratio. There are many more ways we can help our patients with eczema than simply dishing out topical steroids. I think you need to spend time with patients to get them to share with you what's really troubling them with their eczema. Is it the weeping? Is it the crusting? Is it the itching? Is it the sight? Is it the appearance? What is it that's troubling them? But therapeutically, what can we do? Well, I have to say, I tell my patients their eczema will not get better, ever, if they don't stop washing with soaps and detergents. Our ancestors didn't wash. Even Queen Elizabeth I of England only had, in the 16th century, she only had 4 baths a year. Internal running water in our homes wasn't normal until the 70s. In the 50s, I think only 1 household in 7 in the UK had running water inside the house, hot running water. Whereas now people having at least 1 shower more a day, they're often having 2 or whatever, they go into the gym, they're having even more. And worse than that, there's nothing wrong with water. I think a little bit of tepid water on the skin, that's fine. But when you add into that broth detergents, things that form a foam, detergents are powerful alkalis. They're designed to remove grease. Dirt and sweat gets trapped in grease, and they work by releasing grease. That's how they work. But at the same time, they're degreasing the skin. That grease is actually the final part of that skin barrier. Our grease glands produce a film of grease that comes out, usually with our sweat glands around the hair follicles. The sweat sort of pulls it to the surface, and then it forms an oily layer on the surface of the skin, preventing water evaporating. You want to hold that water in the skin. In eczema, you've lost water. The skin becomes dry and cracked and split. But detergents degrease it, and so make it much more difficult for the skin to hold that water. So you need to use an emollient to wash with to re-grease it while you're washing, rather than to degrease it with a detergent. And to maintain the pH, because emollients are buffered to maintain that acid mantle. Then using emollients and using quality emollients that can have 24-hour effect. We've got emollients now that you put them on after your shower, trap that moisture that's got into your skin, leave them there, leave them on, and for 24 hours they'll prevent water loss through the skin. So using sophisticated emollients that way, using cheap emollients to wash with, and it's easy to put the emollients on after your shower because you're naked and you can just cover your skin. It's nice and warm and it's moist and they spread easily. Yes, and use them more often if you want, but emollients, I would probably spend 10 to 20 minutes with my patients asking them about how they wash, whether they're in the bath or the shower, what they're washing with, how long they're there, how hot it is, how often they do it and things, and then trying to improve their washing technique. So use that as an opportunity to re-grease the skin and maintain that moisture long term for the rest of their lives. Yeah, all flares are infected. All eczema flares are infected, but we do now know that certainly in general practice, antibiotics don't alter the outcome of that infection unless the patient's ill. So I like to try and leave the microbiome alone as much as I can. Trying to preserve the normal microbiome. I try to avoid antibiotics as much as I possibly can. So I'm regularly stopping antiseptics and not stopping antibiotics unless there is severe infection or if the patient is ill. And by ill I mean febrile and not functioning and question, should they actually be in hospital? Do they need that degree of supportive care? Just because they've got a flare doesn't mean they need an antibiotic at all. And I'd even go as far as to say I'm thinking more and more about probiotics to try and promote their normal microbiome to fight off the bad bacteria so that they can support that. Another thing not to use is antihistamines orally and certainly not topically. The itch in eczema is not driven by histamine. If it were, we'd be using the non-sedating antihistamines because they would be working beautifully. But we don't. We only ever recommend the sedating ones, and we only recommend those because they enable sleep. And so, but they have a very long half-life. These are very old-fashioned antihistamines. They affect education, they affect driving performance, and I think they should very rarely, if ever, be used. So I'm regularly stopping treatments that shouldn't work or don't work. Yes, topical steroids, and then I think patients need to know which topical steroid to use, where, how often, and how much. And they're not given enough information on that. So we have, in the UK, we just have 4 classes. I think in America you've divided up into 7, but we've got mild, moderate, potent, and super potent, whereas I think you have 7 different groups, from 7 being the weakest. And sometimes I will start with the super potent topical steroid. I only ever prescribe steroids topically as ointments for eczema. Apart, if you've got really moist patch of eczema, for example, in the flexural area, an ointment might just slip off and you might then need to use a cream. But I much prefer ointments, although my patients don't, because they're greasy and sticky and tacky and difficult to use for those reasons. But an ointment has a very low water content, so it doesn't need any preservatives, and patients become allergic to preservatives. An ointment has natural barrier enhancing effects. It helps to prevent water escaping. And an ointment generally stays more where you put it. It doesn't spread so easily. And I say that there's little advantage in using a topical steroid more than once a day. Once a day gives you well over 95% of the benefit of a topical steroid. Using it twice a day increases the potential for side effects with very little additional gain. So use it once a day, ideally at bedtime. And then the fact that it's sticky and greasy and less pleasant to use isn't an issue as much as it would be if you were putting it on during the day when you're trying to use a keyboard or keys and a pen and everything else. And I think patients need to know what we talk about with fingertip units, the quantity that we're expecting them to use. There are not many intelligent things in medicine, but there's one amazing thing, which is that almost every single tube of cream or ointment comes with a 5mm nozzle, which is really useful, which means that when you squeeze out a sausage of cream or ointment from that, the distance from the last crease of an adult index finger to the tip is almost exactly half a gram. Slightly less in women, slightly more in men. And we expect half a gram of ointment to be enough to cover the area the 2 palms of adult skin. So you can work out roughly how much you expect the patient to use, and you can then give them enough supply for them to say, look, this 30-gram tube will cover that area of skin for 1 week, putting it on once a day. So I want to see you in a month, here are 4 tubes, and I expect you to have got through those. So we can be very clear about the quantities that they should be using. But I also think we should give patients very clear instructions about how long they should carry on with them. And the average person with moderate eczema, atopic eczema, has about 9 flares a year, each flare lasting between 2 to 4 weeks. That's 9 months a year they're having a flare. Someone with more severe eczema can have 11 flares a year. They're never out of a flare. And what we'd say is that once the flare's under control, taper the treatment down so it doesn't relapse straight back into a flare. And where my GPs go so wrong is they see the patient in their emergency flare situation and then don't have any follow-up, rather than saying, I need to see you again in 2 weeks' time, and we'll see what we're going to do there. And we're talking then about flare prevention and preventing it getting bad. Steroids are not licensed for long-term use. If you're having 9 to 11 flares a year, you're on long-term use. They're not licensed for that. They're not ideal for that. You will be running into all the problems I described with topical steroids. The next thing just to consider, of course, is what's driving their eczema and what does the patient think is driving it. And that opens up a discussion about things like food allergies, topical allergies, allergies to dogs and cats and house dust mite. And so all those areas often need to be explored and sometimes investigated and sometimes managed. Medical students aren't given enough information about skin disease. I think it's an absolute disgrace how small a profile dermatology has during the undergraduate years of a medical student and a doctor. In the UK, during their 5 or sometimes 6 years, it's not unusual to have had less than a week of tuition on the skin. And some doctors have qualified and think it's a joke that they've had a derma holiday. They think it's quite amusing that they didn't need to attend that, and yet they've passed and they're a doctor. And yet we know this is an incredibly important organ. It's huge and taken over now by adipose tissue, but it previously was the largest organ in the body. It is the critical barrier between this hostile world that we live in with bacteria and fungi and viruses and everything else, and our internal sterile environment. It's incredibly important, and it manifests the most extraordinary spectrum of conditions in response to this environmental world and genetic factors and things. So it is extraordinary to me that someone thinks that they want to learn about the human body and they're prepared to dismiss this hugely, hugely important area. And whether you end up as an orthopedic surgeon or a cardiologist or a GP, you're going to, what you see when you see your patient is the skin, and yet for these doctors the skin is invisible. They don't see it. I've had patients who've been inpatients for several months with a problem affecting their abdomen or their heart or something. And when they come out and convalescent, they say, now's an opportunity for me to just get the skin sorted out. I've come to see you. And they've got the most terrible skin condition. You say, well, how long have you had this for? 30 years. And I say, well, what do they say about it in hospital? No one mentioned it. It is quite extraordinary. So you ask about topical steroids. No, I don't think, woefully little information. Doctors don't know whether to prescribe a cream or an ointment, how much to prescribe, how often the patient should be told to use it, how much to use. And then there's confusion with names as well. So you can have hydrocortisone is normally thought to be a mild corticosteroid, topical corticosteroid, but it depends on which salt it is. And if it's acetate or other salts, some of them are very, very potent. So just by saying hydrocortisone, you don't necessarily know what the patient's using. And I think doctors need to become very familiar with the ones that they're using, and the ones that they're not, they need to look up and know what they're dealing with. So there's confusion all the way through. Are they taught enough? Nowhere nearly enough, no. And because they're going to be used, it's one of the most commonly prescribed drugs, and they're mostly prescribed in primary care, where only 1 in 20 doctors in the UK has done any postgraduate dermatology. So you've got this workforce that's had possibly 1 week and nothing more. in their entire training, and they're now a family doctor responsible for skin disease, which they pick up as they go along. That's a really challenging question, and it's one that exercised me enormously during my 4 years as chair of the Dermatology Council. I felt finally I had a position where I could perhaps make some change. And my first port of call was to the Royal College of GPs and saying, look, GPs, a huge amount of GPs' workload is managing skin disease. We know that. It's almost a quarter of every consultation includes a skin problem of some kind. And it's estimated that around about a seventh of our total workload is managing skin disease. So it is a huge part of the everyday working life of a GP. We need to make this a priority. And I was banging my head against a brick wall. I couldn't get them to get it. In the end, I went to the chair of the Royal College, and she was very lovely. She listened, and she got it. And she said, I agree, we need to do something about this. I can see the problem. But it was too little. And when I moved on, it rapidly died, and very little came out of that. I think our medical schools need to have a complete rethink about are they really training doctors to be fit for purpose? I don't think they are. I think we're increasingly looking at alternative practitioners, pharmacists and nurses, and I think they often have the skills, and it's not difficult. Dermatology isn't challenging. Yes, certainly into tertiary levels, it's fascinating and extraordinary, and I find it very complicated. But what I'm talking about is the management of these common conditions: acne, eczema, psoriasis, rosacea, lesion recognition, hair problems, pigmentary problems. These aren't difficult to manage on a primary care level really well and make a really big difference. And I think whether we look at other practitioners to help with that and train them to manage different parts of the world of dermatology, I don't know, but it's definitely an area that needs. Our patients are being let down badly currently. I think that there's definitely a lack of concern for TSW patients by the professions. I think the profession, I don't know why it's proving to be so difficult on this area. I think that many doctors feel uncomfortable when they're dealing with something they don't know much about. They don't like that feeling that the patient perhaps knows more than they do. And it doesn't fit into their model of what's going on. And they can squash it and move it around a bit and make it fit into models that they can think of, and then put the blame on the patient. And that is much more comfortable for the doctor than acknowledging that there's something else going on here that they need to think about. The profession's been remarkably blinkered and almost feels that there's a conspiracy going on, or the patients think there's a conspiracy theory going on, and it's created a war. And we don't need wars. We just don't. We need to listen to each other. We need to respect each other. And I suspect there's an element of both sides have an argument that needs to be heard and listened to and respected. But I don't think the patient's voice is being heard adequately and appropriately at present. Rarely patients become allergic to their topical steroid. You can actually be allergic to the topical steroid molecule. More commonly, you can be allergic to a preservative in the vehicle, particularly if you're using a cream. And then you put the steroid on, you're getting an allergic reaction. You put more on, you get a more severe reaction. That's an allergic reaction, and that does happen. It's not that common, but it's happening, and we do now recognise that. There are, I mentioned before, some skin conditions that are driven and flared by topical steroids. Perioral dermatitis is the notable one. If you don't stop the steroids, that won't get better, generally, in my experience. They're nearly always driven by a topical steroid. Often inadvertently, the patient didn't realise that this product had a tiny bit of steroid in it, or they're treating their child's eczema and a bit gets on their face and so on. So that's a condition where withdrawing the steroid is critical to the management. And when you withdraw it, the condition gets worse first. So it's a difficult phase to get through, but it's really important. And there's a well-recognized rosacea as another, aggravated by topical steroids usually, and acne can be aggravated, and so on. But then we have the big thing, which is topical steroid withdrawal problems, which the profession is wanting to believe is very rare and is saying it's rare. And the problem with saying that is that if you say something's rare, many doctors won't look for it, won't recognize it, won't see it, won't diagnose it, and it remains underdiagnosed. And so it becomes a self-fulfilling outcome. You say something is rare, you don't look for it, you miss it, it remains rare. It's rarely diagnosed. It doesn't mean it's rarely a problem. And I believe when you look at careful population studies, it's as common as 10 or 12%, and I suspect massively more than that. I think that a lot of these conditions that we think are uncommon, when you start looking for them, you find out that they're not as rare as you thought they were, and then you think, goodness me, this is very interesting. It's not helped by the fact that the definitions aren't clear, and we can't put our finger on exactly what it is, and I suspect it's probably an umbrella diagnosis with different elements within that, which are different ends of the spectrums, and so it's not helped by that. But it is undoubtedly, in my mind, more than eczema that's not being adequately managed, because it's not confined to where the eczema was, for example. It spreads further. It's worse than it was when it started. I don't think it involves the palms and the soles, generally, but I think it pretty well can cover any other part of the body. Maybe I'm wrong there. I don't think I think that it's not helped by having different names either. We need to come up with one entity, and we need to start trying to define what we mean by that. And then I think it'll stand a better chance of being recognized and its prevalence being adequately acknowledged. And then it'll be appropriately addressed and managed by the profession. It's not just medical students. I agree they are our future doctors, and therefore will have an incredibly important role. But I would love to see it getting into the hands of our current cohort of doctors and nurses and pharmacists. It's not easy. I really don't think I haven't got the magic bullet for you, I'm afraid. If I was a young doctor doing dermatology, I'd love to do a PhD on this. I mean, what a ripe area of research. You know, it would be fantastic to make your name. You need some charismatic young doctor who's going to become a future professor at some prestigious unit and make it their real expertise, and they'll have a large number of patients and a large research base, and it could be absolutely fantastic. It'd be a very exciting thing to be going into, and you could help a huge number of people quite dramatically. And you've got the alternative treatments at your fingertips. 20 years ago, 25 years ago, we really didn't have a huge amount else to offer, whereas now with all the other drugs we've got, suddenly the field has opened up for alternative ways of looking at things and managing things. Education, isn't it really? It's what you're doing, the work you're doing is fantastic. Just getting this word out. Clarifying where your condition, this condition, is different from those other things that doctors are trying to pigeonhole it into. So doctors are trying to say it's undertreated eczema. Why is this different to that? To provide a clear distinction so we can have a line between the two. And obviously two are interconnected as well. If you've been on steroids that have been controlling your eczema and you stop those, it's not surprising the eczema is going to get worse as well. So you've got to manage that as well. And I think we need to move into the world of prevention. Yes, steroids are going to continue to be the frontline agent for doctors to use, but I think that they need to be rapidly on to things when they're not working or patients are reporting that they're causing problems, and not to persuade their patients to blunder on beyond the point at which they're beginning to cause problems. So yeah, maybe 9 out of 10 patients who use a topical steroid, it works fine. have an episode, clears it up, on they go, forget about it. And you won't hear from those patients. But when they come back and say, I've got a problem here, realize that that particular patient needs more time and more thought and thinking outside the box. Yeah, the way in which we measure the potency of topical steroids, I was talking about the different strengths of topical steroids. One of the ways in which you can measure the potency of a topical steroid, interestingly, is you establish how much, or you measure how much vasoconstriction it causes in the skin, so how intense that is and how long it lasts for. So a potent topical steroid causes intense vasoconstriction, making the skin go white, and that can last for quite a long time, whereas a mild one doesn't do it so dramatically. Now, blood vessels, when you cause them to constrict, it's not surprising that when you withdraw that, they will rebound. And for many patients, that can be a real problem. The skin becomes quite red, quite sore. That redness is painful, and it's often genital skin or facial skin, particularly that it goes for. And they sometimes find that the only way in which they can get relief from that is to put more topical steroid in, because that causes more vasoconstriction, and then they're getting into a vicious cycle. And so we know that steroids have an effect on the vascular supply to the skin and causing vasoconstriction. Vessels, that's not how I would normally thought a steroid should be working. It's an intriguing marker of their potency. Why should vasoconstriction equate also to its immune suppressing benefits? But it clearly has an impact on the vessels, and I think that's an area that definitely merits more research. I think it's a very, very exciting time for skin disease in general, but eczema is one of the diseases I think we're going to see fantastic development. The rate at which we're understanding the pathophysiology is quite extraordinary, and I think that with that is coming the most fantastic therapeutic advances. And so I think that we're into a very, very exciting era. We've seen the prevalence of eczema go through the roof in my lifetime. When I was a little child, or even before that, 70 years ago, eczema was uncommon. We didn't wash. We left our skin barrier alone. We didn't have antibiotics. And eczema was rare. Lots of differences, I know. But it has just increased relentlessly. It is plateauing in preschool children now at about 20–25%. And around 10% of adults have eczema that disturbs their life. But I think we'll hopefully begin to understand where we've gone wrong in this 70 years and address that, and hopefully get into the world of preventing it. I think that my ancestors didn't have eczema. Why have my grandchildren got eczema? And what's changed? And can we change things back to how they were? Better diet, less antibiotics, more sun. It's another controversial area I have interesting views on. Definitely more vitamin D and less washing, or washing with emollients that preserve the pH and re-grease the skin and look after the microbiome. I think understanding the microbiome is going to be fascinating. But these therapeutic advances, I just am in awe of. And yes, they are always anxious because you're knocking out one member of the orchestra that's been playing out of tune. But it doesn't necessarily mean that the music sounds the same. And things can then start to really get out of kilter and go wrong. So we have to keep a very, very vigilant eye when you're using such powerful drugs. But we are targeting them more and more, fine-tuning, and I think that's incredibly exciting. So the treatments we had in the 20th century, phototherapies and immune suppressants and powerful drugs that caused terrible side effects, hopefully we'll see the end of those days, and we'll go into much more targeted therapies. So yeah, I'm very excited about where we're going to be in the next 10 years, and beyond that, wow, who knows, with AI and things, it could be even more dramatic. But we mustn't, throughout all this, lose the fact that we're dealing with a human being and a person who has their own worries, their own concerns, their own ideas. we need to make sure we always keep the basics at the front of our mind. It's very easy for these unbelievably clever specialists to be using unbelievably clever drugs. But a number of times I've seen a patient who's waiting to start something like a biological, and they come to see me because things can't start for one reason or another, they're pregnant or whatever, for a few more months. And I say, well, what do you know about washing? And I go right back to the basics. And they say, no one has ever discussed that with me. And I see them 3 weeks, 4 weeks later. They've corrected things, they've stopped the antihistamine, they've stopped the antibiotics and the antiseptics, and they've started to use emollients competently, and they're washing back. And they say, I don't think I need that biologic. I've had a number of patients over the years, a large number, who've come back saying, we've got the basics right, I know where I'm going now, and it's changed. So we mustn't lose, yes, we've got sophisticated drugs, and yes, they're going to have a fabulous role for those patients who need them, but we still mustn't lose contact with the really important thing, which is the vast majority of people's lives will be changed dramatically by making those simple changes. They have been banging their head against a brick wall and a closed door, and it's time that door was opened and they were welcomed in and said, let's get round the table and you tell us what it is that you're concerned about, and let us tell you what we are worried about. And I think we need bodies that advise doctors and are funded by the government, so nice in this country, to begin to look at it in a much more holistic way. I think NICE is too driven by being cost effective and not driven by clinical and health excellence. And money, the cost of the treatment is an important part, but not the only part of what you need to, the outcome that you need. And often treatments that might cost more per tablet or per tube, because they work and they're used and they're effective and they're safe and they're free of side effects, they can control the disease and the outcome is massively less expensive. Yeah, sometimes when I'm giving lectures I say, I do this with acne and with psoriasis, I say, now I'm just going to go through the NICE guideline. Have you heard of NICE? And I get a sort of slightly nervous twitter of laughter, and I say, yeah, yes. It's the National Institute of Cost Effectiveness. And I say, and they take their responsibilities very well. And if you go through this guideline, you can see that the word cost effective comes into every other page. And if what you're concerned about is cost effectiveness, yeah, you've got to be sure that you're looking at the right parameters. And it's not just the cost of the treatment, but wouldn't it be lovely to have a National Institute of Clinical and Health Excellence? I mean, that would be amazing. I think doctors are under enormous time pressure. There's no doubt about that, for a variety of reasons. And time is one of our most valuable commodities. You can do it well and do it quickly, and you can learn the tips for doing that by listening and asking open questions. But to give yourself, to release yourself, to not want to say, when did it start, when did it finish, what are you using, what is that? Instead of saying, tell me about your eczema, giving the patient some control. It sometimes backfires and the patient heads off for 20 minutes, half an hour, on a long story about things, but more often than not, they realize and they respect your time and they will tell you what you need to know. I would say the patient's history is the most important part of the consultation, and it is his story. The history is his story, or her story. And I would always start a consultation having initially introduced myself and basically just announce that this is a doctor-patient encounter, because often my patients are my friends. But here we are in the office or the consulting room, and now I'm the doctor and they're the patient. So lay the ground rules a little bit and say, just sit back and say, tell me about it. What's going on? Followed by looking and actively listening for up to 2 or 3 minutes. Quite a long time to invest. Nearly always, at the end of that, you will know what the patient's thinking about, what they're worrying about. And then what I'd do is I'd repeat it back to them. So I'd say, well, I'd summarize it and say, well, look, what you're telling me is you're about this, this, that, you're using this, you're not happy about it, and so on. Are we on the same page? And then I'm in a position where I can start thinking about it, whether I need to examine them or whether I need to find out a bit more, elaborate on an area, before we can then negotiate a shared management going forward. And that actually really works effectively. It doesn't take loads of time. It's releasing that control. Doctors like to feel they're in control. They like to ask direct questions and get direct answers and make it all very precise. The more you can hand over and let the patient take control, the more effective things can be. But yeah, I think that the time pressures do mean that you necessarily have to assume that more common things are common, rare things are rare. I used to say there are so many rare things that I commonly encounter something rare, and I was always alert and vigilant to the unexpected and the unusual. And my partners used to tease me saying, well, George will know because it's rare. But I think you need to be constantly vigilant for that, because things aren't always going according to plan. But I agree, time is a major risk for missing the unexpected and trying to force things into the wrong pigeonhole. If it's not fitting, stand back and think about it, and put the patient back in control. And after all, they're living with their skin, they're living with their body 24/7. They nearly always know. Patients are usually right. So when my patients say they don't like something or they're worried about something, nearly always it turns out that they were right and I was wrong, or the profession's wrong. So at the end of all this consultation, I always have a bit of what I call housekeeping, which is just getting myself back calm again. I remember I had a lovely young mother come and see me for her first pregnancy. She came to see me and she said, "Come to see you, Dr. Moncrieff, because I'm pregnant." I said, "Fantastic. I know you've been trying. That's such good news. Right, tell me what's going on." And we worked out all the things you needed to know, and I talked about soft cheese and lambing and avoiding the sheep and what immunisation she should have had and what this, that and the other, and when she's going to have scans and all the works. We went through the works. I knew it was going to be a longish consultation, but we went through all the details of what to expect and what her thoughts and hopes were and where we were and what the next step was going to be. Would you have it, the next patient who walked in said, "Hi, Dr. Moncrieff, come to see me, I'm pregnant." So I said, "That's good." I said, "Okay, here we go again." And I went through it all over again. 15 minutes later, in a 10-minute consultation, I was now running 10 minutes late, which I don't like. Off she went. "Would you have it?" The next patient came in and she said, "I'm pregnant." And I said, "Oh shit." And that wasn't fair. It wasn't fair on her, because she should have had exactly the same reception as the first patient, and the only thing that had changed was me. And you know, I think sometimes you just have to clean slate, and now you move forward, and it can be difficult on our side of the table.